Hello, welcome to this mini-gem. Why do we need evidence-based medicine in geriatric medicine? The learning outcomes that I hope you'll take home from this lecture are to understand the principles of evidence-based medicine, to understand why evidence-based medicine is particularly important to geriatric medicine, and to consider how you can embed evidence-based medicine into your own clinical practice. Evidence-based medicine, or EBM for short, incorporates not only a thorough search of the available scientific literature, but also combining this with clinical judgment, expert opinion, and the patient's own values and preferences. It's only when all three of these aspects are combined that EBM truly takes place in clinical practice. So why do we need EBM in geriatric medicine? Well, let's look at Mrs. Bloggs, who is 82 years old. Historically, she may have been excluded from research due to age alone. Fortunately, this is happening less and less, but she may still be excluded from research due to reasons such as polypharmacy, frailty, cognitive impairment, and multiple comorbidities. Now, some may argue that this means that we should ignore all research as it does not apply to her, but this just deprives her of the same treatment that would be offered to her younger counterparts. Now let's use an example. Mrs. Bloggs goes to see Dr. Brown. She explains that she's worried about her blood pressure being too high, as she has read that very low blood pressures are better for the heart. Now, if Dr. Brown knew nothing about the principles of EBM, he may simply say, "Nonsense! At 82, your blood pressure should be the least of your concerns. Here's another prescription." Now let's assume that Dr. Brown understands the principles of EBM. So Dr. Brown goes away to read up on this subject, and he discovers the SPRINT trial. He learns that, in this trial, intensive blood pressure management compared to standard blood pressure management lowered the risk of death from any cardiovascular cause, as well as all-cause mortality. He looks at the paper in more detail, and he discovers that this effect is clear-cut, but that this effect doesn't diverge until after at least the first 1 to 3 years. He wonders if age might have affected this, and discovers that, in fact, this effect was much clearer in those aged 75 years and older. Next, Dr. Brown checks the inclusion and exclusion criteria of this trial. He notes that the absolute maximum number of medications patients enrolled on this trial could have been taking was 4 medications. He notes that patients with diabetes mellitus, history of stroke, or with a predicted life expectancy of less than 3 years were excluded. Patients with dementia or those resident in a nursing home were also excluded. Next, he looks at the adverse events reported in this trial. He notes that patients within the intensive treatment group had significantly higher rates of syncope, bradycardia, hypotension, and abnormal laboratory results. Some of these requiring hospitalisation. Next, Dr. Brown looks at Mrs. Bloggs' own past medical history and drug history to consider how the results of the trial that he's looked at relate to Mrs. Bloggs. He notes that she is currently taking 6 medications. She does not have a history of diabetes, stroke, or heart disease. She is on treatment for hypertension, but her most recent last 3 readings have all been below 140 systolic. So Dr. Brown goes back to Mrs. Bloggs, and he starts by saying, "I have looked into what we have talked about, and I now have all the information, but I want you to be involved in the decision-making process." And of course, she may simply say, "Do whatever you think is best." However, Dr. Brown realises that in order to make a holistic decision about what is best for her, as well as her past medical history and drug history, he needs to know a bit more about her functional history and social setup. So she explains that she lives in her own flat, but that there's always someone on site with her. She normally uses a stick to walk with when she's outside of her flat and gets food delivered to her house. She goes out to bingo regularly and likes to see her children at weekends. Dr. Brown then proceeds to ask her directly, why was it that she was worried about her blood pressure? Mrs. Bloggs responds that her grandson is getting married in 9 months' time, and she is concerned that she wants to ensure that she is alive for when he gets married. Dr. Brown then proceeds to give her all the information relevant to this. He explains that her most recent blood pressure measurements have been very good, and that what she has read is correct, and there may be some benefit to lowering blood pressure further for some people. However, he explains that this benefit is more in the long term, and it's unlikely to change what happens in the next 9 months. He explains that if we were to lower her blood pressure further, she'd probably be more likely to have more faints or faint-like episodes. After considering all the information, Mrs. Bloggs and Dr. Brown together come to a decision not to proceed with intensive blood pressure management for the time being. This case has reinforced the principles of EBM, specifically with reference to geriatric medicine. In this case, Dr. Brown consulted the relevant scientific literature. He incorporated this with his own clinical judgment and expert opinion, and importantly with the patient's own values and preferences. The learning outcomes that you will have achieved from this mini-gem are to understand the principles of evidence-based medicine, to understand why evidence-based medicine is particularly important to geriatric medicine, and to consider how you can embed evidence-based medicine into your own clinical practice. Thank you for listening to this mini-gem. I hope that you have found this useful. You may find these references helpful for future reading in relation to evidence-based medicine in geriatric medicine.